Results presented at a recent meeting of the Academy of Managed Care Pharmacy showed that giving empagliflozin to patients with type 2 diabetes and established cardiovascular disease produced savings by year 3 and substantial savings by year 5. So how do studies of cost effectiveness affect coverage decisions for payers?
Yeah. So I'll start off that the coverage decision starts with the question of the scientific evidence. Should any type of therapy, drug, technology, device, is there coverage or not? And that's really separate, divorced from the cost of either the cost of the therapy or even savings. Once the scientific data is established that it's effective, then the question comes in, well, what does it cost and how is that going to fit into a benefits plan? And so obviously something that, in addition to being scientifically valid, also saves money. Well, that's about as easy as it gets. Those that are scientifically valid and cost some money, those are very likely to still be approved. And those that are scientifically valid but cost a lot of money may still well be approved, but they may get more scrutiny to make sure that they're being utilized for the appropriate patient in the appropriate way so that there's not misuse or abuse. But the decision of whether there's coverage or not starts at is it a scientifically valid or validated therapy that makes sense for folks to be using? And then from there, it then moves off into okay, once you've said yes, now how do we pay for it?
What about the time horizon? Does that enter in, thinking about when those savings accrue and who they accrue to, especially for a payer?
Well, it certainly, is an issue. Once you've made that decision, and you start looking at the finances behind it, or the finances going forward, the time frame obviously plays a role. We know that members move on for any number of reasons. If they're getting their coverage through their employer and they change jobs through no desire in anyone for them to move, they may very well change payers, and this may happen several times. So that does enter into how the cost effectiveness issue enters into a decision. But as I said, that's only coming after the concept of whether it should be paid for in the first place.
This gets back to the discussion that we had earlier on how fractured the American healthcare system is. And when we have long-term illnesses such as diabetes, where what you do for the next week is of relatively little consequence, unless you're going to prevent a heart failure episode with an SGLT2, but our concept is that we really want long-term care delivered over perhaps decades. And we have to somehow say to ourselves, how can we change the system so that a treatment once established can be continued in a relatively seamless fashion when it's appropriate? It's hard enough for our poor patients.
I think from the provider and patient, perspective, it brings to the forefront this issue of class effect or not, because typically if a drug's found to be effective, it'll be covered by payers, and for the most part, but they may choose one of the analogs based on price and et cetera. And if all of them are shown to be equally effective, then that's great. But if it turns out that there's ambiguity there, and right now we're still in an area of some ambiguity, it makes that much more problematic. So that's really where I think we'll have a sense over the coming months whether studies now confirm that there's a class effect or not. For most other drugs, that has been the case.
Having substitutes allows for some price negotiation.
Yeah, exactly.
Right. Well, this has been a great discussion, and I really appreciate all of you joining me for this and your insight. But before we end, I wanted to open the floor and get some final thoughts from each of you. And Dr. Bloomgarden, if we could start with you.
I would simply say that this is an extraordinary and exciting time to be in the diabetes field, and I feel fortunate to have been involved long enough to see this come to pass.
Dr. Gabbay?
I echo that this is a tremendously exciting time, and I think the two big headlines here is that there have been 2 drugs shown to reduce cardiovascular mortality, and that's a big step forward in the field of diabetes, because in the end, that's why our patients with diabetes die.
Dr. Inzucchi?
So I'm equally excited as my colleagues. I'm also excited because this observation of improving cardiovascular outcomes with glucose-lowering medications, which has perplexed us, as I mentioned before, for decades, is now forcing our scientific colleagues to look at this relationship between diabetes and heart disease. And I don't think it's a relationship that we fully understand. It's really at the intersection between our understanding of vascular biology and metabolism that I think is fascinating. Why does liraglutide reduce cardiovascular outcomes? Is it simply because it reduces weight and blood pressure and glucose? My sense is probably not. Why does an SGLT2 inhibitor like empagliflozin improve cardiovascular mortality within months and heart failure hospitalization? Is it simply because it's a diuretic? Our cardiology colleagues would say there's no other diuretic that does that. Some have proposed that there may be a ketone mechanism, that a slight micromolar increase in beta-hydroxybutyrate may feed the heart substrates that it enjoys, eating more than free fatty acids and glucose. So I'm excited both from our ability to help our patients, getting this monkey off our back, frankly, of glucose-lowering drugs not improving cardiovascular outcomes, but also this new need to understand diabetic heart disease.
Lots of opportunity for science. Finally, Dr. Snow.
Diabetes has always been one of those situations in medicine where it was just a very negative associated with it. It's increasing in frequency. The prevalence of diabetes is increasing. Folks will develop complications, microvascular complications. They die of macrovascular complications, and the news is always bad. And what's happened over the last decade, 2 decades, or certainly, and now progressing, is that we have slowly chipped away at that. Through better understanding of what we're trying to achieve, through better therapies that are available, through better care that's provided, we have chipped away at the microvascular complications, and now we've chipped away at the macrovascular complications, and now we have even further agents that look like we'll be able to chip away at this in a big chip. Much more, and so we can really give patients an upscale message that yes, it's diabetes, but you can live a long and healthy life despite having diabetes.
Great. Well, thank you all for joining me, and thank you for your contributions. On behalf of our panel, we thank you for joining us, and we hope you have found this AJMC Peer Exchange to be informative.